Welcome to this installment of the series that my friend Christine Alessandro from Bay Path Elder Services and I are doing here at the Northborough Senior Center regarding kind of a series of issues that we think are relevant to seniors. And what I want to do today, this presentation got inspired by Christine, who really inspires most of the things that I do with Christine, who is, I think you've met her, she's the executive director of you're the officially executive director or the president? Executive Director of Bay Path Elder Services, which is the aging services access point, the entity that serves this entire area. They have a total of 14 communities that they serve. And did I get that right? I got that right, yeah. And they are basically the funnel through which all state and federal money for seniors flows. So they are in the position to kind of know pretty much anything that you need to know about senior-related issues. So Christine had suggested to me, she said, you know, there's this big change happening in Medicare in that so-called Medicare C plans or Medicare Advantage plans are being allowed to offer services that have not traditionally been allowed to Medicare recipients. We should do a show about that because nobody knows about this and it's a big, big deal. And I said, okay, so let's do this show. And then I found myself saying, so before we kind of talk about what Christine is going to talk about, I thought that we would probably should do a little bit of background for your benefit and for the people who are watching this about kind of what Medicare is, because if you need to know that in order to kind of put into context what Christine is talking about. So you all know my friends Frank and Mary and their kids Peter, Paul, and Mary Jr. We've all talked about them before. As you know, their goal is to live in their house until they die and be buried in the backyard. And a lot of times, or a lot of conversations about Frank and Mary are about, oh, what if she needs nursing home care? Oh, you know, how do you deal with Medicaid? There are a whole bunch of other issues. But the most common thing for Mary to need, if she has a health problem, is Medicare. And so we're going to talk about today just about Medicare. So a brief history of Medicare. Medicare was created in 1965 at the same time that Medicaid was created. It was created by Lyndon Johnson. It was part of these many Great Society programs. To give you a sense of the impact of Medicare, in 1960, before Medicare was created, 33% of senior households were considered to be poor. That number in 2010 was 7%. Now remember, in 1960, Social Security had already been there for 25 years. So what really changed, and it's hard for us now to even conceive of that number, of how many seniors were poor, was Medicare. This is what changed, because before then, older people, of course, would get sick, and they couldn't pay their bills, and so they go broke. And that's what would happen, like over and over again. So, eligibility for Medicare. You all know about this. You need to be 65 or older. You need to have paid in at least 40 quarters. Or your spouse has to have paid in 40 quarters of Social Security money. You also can buy in, although we're not going to talk about that because that's such a rare thing. Medicare, when you hear about Medicare, you just about never even hear about Medicare C. You typically hear about Medicare A, B, and D. Well, we're not going to talk about D today because D is the drug plan. We're going to talk about Medicare A and B because C is related to A and B. So to understand how C works, everything that you learn about C, or that you learn about A and B in terms of the benefits, all apply to C, 100%, okay? So Medicare A covers 4 things. It covers hospitals, covers nursing homes, it covers homebound care. We're going to talk about that a little bit because most people don't know that exists. Covers hospice care. We're going to talk about that very briefly. So Medicare A covers hospital care. That is, everything that happens, all of your care while you're in the hospital, that the hospital provides. So it's not covering doctors. And we're going to talk, because that's Medicare B. So it covers all of your hospital care from the day you're admitted, and we're going to talk about that a little bit. There is always a deductible. There's the Medicare deductible, $1,340 for every hospital visit. Many people aren't aware of that because when they bought Medicare, they bought a Medigap plan too, and that's one of the things that the Medigap plan pays for. But there is a deductible if you don't have the Medigap plan. Once you're in the hospital, it covers 90 days worth of hospital care. Your first 60 are free. Your last 30, though, there's a $335 per day copay. Wow, that's a big number, right? So there's a $9,000 a month, or about a $10,000 a month copay if you're in the hospital for a prolonged period. So you get up to 90 days. And then in addition to that, every time you're sick, every time you have a period of illness, and a period of illness is defined as one in which you are admitted to the hospital, okay? Every time you're sick, you get those 60 days or those 90 days. In addition, there's another bonus day, some other bonus days that you all have automatically under Medicare. But that's only another 60 days. So the total that you get under Medicare, that you can possibly get under Medicare during one period of illness, is that 90 days plus the 60 or 150 days. And if you've used up those reserve days, you can only get that, they only apply once. And during the reserve days, look at that, there's a $670 per day copay. So your copay is $18,000 a month for those last days. Finally, remember, you get this benefit during any period of illness. So if you're, and the period of illness, as far as Medicare is concerned, ends 30 days after you've been discharged from the hospital. 30 days after that, if you get sick again, there's a new period of illness. Possible issues with Medicare, this is one that you've probably heard about a lot, right? It gets brought up a lot, is, are you really in the hospital because you have been admitted or not? Admission to the hospital, once you've been admitted, you're there on Medicare A. If you're there and you haven't been admitted, even though you really look like you've been admitted, like you're in a room, you know, there's a room and they're feeding you and all that stuff. Unless you've been admitted, you're there on observation status. And observation status has been a very popular recently as Medicare, as the folks at Medicare try to keep costs down by keeping you from being in the hospital admitted. Because once you're admitted, then the Center for Medicare and Medicaid, the entity that runs the Medicare system, has to pay a lot of money for more money for your care than if you're just there on observation. If you're there on observation, you haven't been admitted. Therefore, you're being covered pursuant to Medicare B. And pursuant to Medicare B, there's a copay, right? There's a copay. So there is some, and the other reason is, one of the main reasons is, we're going to talk about this a little bit when we get to nursing homes. Many of you may know that you are entitled under Medicare to some nursing home days, up to 100 per period of illness. What is a period of illness? It's a period that follows a 3-day stay in the hospital once you've been admitted. It includes the first day that you've been admitted. It doesn't include the day of the discharge. So if you go to the hospital and you're in the room and they're taking care of you and everything, but you're only on observation status, and then you go from there to a nursing home, your very first day at the nursing home, you're on private pay. This is a big deal. It hits a lot of folks. The reason why you want to, so that's a big issue. The second issue is just the general issue of, are you being discharged too soon? In general, when you go to the hospital on Medicare or on your own health plan, Medicare has divided every possible kind of thing that could be wrong to you into these categories, these diagnosis groups. And based on whatever group you fit in, at the day you're admitted, Medicare is going to assign the hospital, they can be able to tell the hospital, this is how much we're going to pay for this person, right? For you taking care of them right now. Whether you take care of them for 2 days or 10 days. Same amount. So the hospital is really interested in minimizing the number of days that you're in the hospital, because they're getting paid the same thing no matter how many days you're staying in the hospital, with a few exceptions. So, two issues regarding hospital are you really, have you really been admitted, right? And you have the right to ask at the hospital whether you've really been admitted, right? And are you being discharged too soon? And you can't be discharged from the hospital unless you have been notified in writing that they intend to discharge you, right? If you're just there on observation status, There is nothing that they have to tell you right now about that. So if your question is, well, what do I do if I think I should be admitted, or alternatively, I don't think I should be discharged? And the real answer is to find an advocate. And that advocate at that point shouldn't be your lawyer. We don't understand this stuff. I mean, I shouldn't say we understand the procedure, but we don't understand the medical terms. We went to law school because we didn't want to learn that stuff. The other guys went to medical school. They like that stuff, right? So the people who have come to play that role, like for a lot of clients of mine that I strongly recommend, and I'm telling you ahead of time, you ought to know one of these people. Because when you go to the hospital, it isn't because you've been planning to go, you know, oh boy, I've been dying to, I knew this emergency was coming. It's because you just show up. So you need to know ahead of time the person you can call if this is an issue. The people that typically do this kind of work are called geriatric care managers, or GCMs. They have, for some reason that is beyond me, started calling themselves something else, so that everybody who thought that they were GCMs are now called aging life care professionals. They all agreed in their national organization that people didn't like hearing about geriatric care managers because it had the word geriatric, and so they changed it to aging life care. It was just dumb. But anyway, you need to know one of these people, and you need to know them before you need to know them. You know, you don't want to be calling them. I mean, they'll take that call at the last minute. I have that happen all the time, right? But you need to know them. The people who will, I mean, I know a few of these people, and I can recommend a few. The people who will know the most are Christine. Christine and Bay Path Elder Services, one of the things that they do, I mean, they maintain this terrific website, which I think she could talk to you about. Really, of all the resources that are available to anyone in any of their 14 communities, and they actually divide their website by community. So you can click Northborough and say, okay, so who's available that I might want to talk to who is in Northborough? So that's a great source. But I'm telling you, you need one of these people. So the basic Medicare appeal system regarding admission and regarding discharge, right? Regarding discharge, before you can be discharged, once you've been admitted, there has to be written notice of the hospital that you're going to be discharged. And then from that moment that you have signed that written notice, or your person who is your healthcare proxy has signed it, you've got like 48 hours to appeal, like a really short time to appeal. You want that geriatric care manager there right away so that they can do that appeal for you. You don't want to be trying to figure out where the QIO is. The QIOs are entities that are hired by Medicare to handle the appeals process. Medicare is so gigantic, they don't even do their own appeals. They hire somebody to do the appeals, not, to actually be the judges, right? So you don't want to be trying to figure that part out. Regarding admission, remember, as I mentioned to you, you may be there and not even know that you're on observation status, right? But they got to tell you if you ask. And if you ask, you can appeal that decision. You can appeal that decision. And you may find that appealing that decision is very valuable to you because if you were admitted, then remember there's no copay, right? If you're admitted, it may make a real dollars and cents difference to you. And if you've got a family member who has gone into the hospital, and you're concerned that they may be ending up in a nursing home, then you really want to get this done. Because you want every mechanism of making sure that, unless you've done a lot of planning in advance, right, that the moment that person leaves the hospital to the nursing home, that person is already eligible for Mass Health, eligible for the Medicaid program. You're not going to have time to do that if they're only staying at the hospital for 3 days, and the day they show up at the nursing home, they're on private pay. You would have time to do that if they had been admitted to the hospital, been there for 3 days, and therefore you know that some of their days in the nursing home are going to be covered by Medicare, okay? So that's really important to you. The nursing home benefit, in order to qualify, has to be 3 prior days in a hospital, admitted, not observation, first. And second, you need to show that you need skilled care at the nursing home. That is, the care of a nurse, physical therapist, or occupational therapist, and that you need them really on a regular basis. So this is not the kind of care that could be provided at home. In no case will Medicare pay for more than 100 days following your discharge from that hospital. Once again, you get a new 100 days during each period of illness, but never more than 100. The median amount that Medicare pays for is 17 days. 17 days. Boy, that's not very much. Now, why is that? Well, I'll tell you one of the reasons. That is, for years, and it turns out contrary to the law, Medicare and all of the agencies that were working for Medicare had agreed that unless the skilled care that was being provided to you in that nursing home was necessary in order for you to get better, to improve, that Medicare wasn't covering those days. And that's why you would often hear terms like, oh, she's plateaued. Oh, he's gone back to baseline, and therefore Medicare will no longer cover the benefit. That has never been the law. And finally, as a result of a case that got brought called Jimbo versus Sebelius, in which some folks in Vermont sued Medicare. And Medicare finally, after the judge was unwilling to dismiss the case and Medicare knew they were in trouble, so they settled. And they agreed that they would change all of their regulations in order to try to make it clear to all of the players that skilled care is necessary and will be paid for by Medicare if it is needed either to stay the same, that is to keep from getting worse, right? Or to keep from getting worse at such a fast rate. So if the effect of the skilled care, and this is really important, especially for so many of my people who've got dementia-related issues or Parkinson's, a lot of diseases where you know people are going to go down, right? That's kind of the direction they go. People don't get better from this stuff. But the question is, can you slow it down? Can you slow it down? Can you slow the rate of decline down? If you can show that that's skilled care, and often in the case of folks with some form of dementia, that occupational therapy is a key piece, right? That skilled care can slow down that rate of decline, then Medicare will pay for it. So, as I say, it may be worth fighting for. The reason why I mention this is that nursing homes basically hate this, right? And the reason is because if you're in the nursing home and it is determined that you are no longer getting better, but that, as far as Jimbo versus Sebelius is concerned, you still need this skilled care. You need whatever, the physical therapists or the occupational therapists, in order to stay the same. Medicare will keep paying, but they keep paying at a much lower rate. Medicare, if I recall correctly, has 61 rates, depending on the amount of care that you need. I mean, it's a bureaucracy. It's like the IRS, you know, so you get a ton of these rates. And the one that they'll pay if you're in this situation is very low. So from the nursing home, but if you're on Medicare, then the nursing home has to be providing these services. They need to be providing the physical therapy or the occupational therapy. Whereas, if you're on Mass Health, right, which most people in nursing homes qualify for, over 80% of all people in nursing homes in Massachusetts are on Mass Health, then the nursing home no longer has to provide those services. They no longer have to provide physical therapy, occupational therapy. They can just let you sit there, right? So from the nursing home's perspective, they make more money if you're on Mass Health than they do, or about the same money as whether you're on Mass Health or if you're on Medicare at this very low rate, right? But they have to do less work. They have to provide no physical therapy, no occupational therapy. So they're going to be telling you, oh no, sorry, your husband is plateaued, there's nothing we can do. You're either on private pay, which they really love, right, because you're paying such much higher rate, or you're on Mass Health, right? So from your perspective, the issue is, once they're on Mass Health, as I mentioned, those extra services go away. You know, if you have a person who you think needs to be there because they've got dementia, they can't be safely at home, but they could also really use these other skilled services, then either you have to pay for those services out of pocket if they're on Mass Health, or you have to fight about it because you want to keep them on Medicare. Third, the home care benefit. the home care benefit, who knew? So did you know that you can actually get Medicare to pay for doctors and nurses and some home health aides to be with you at home, even if you haven't been discharged from a hospital, just because you're just at home and you need those services? The answer is you really can, and that's what the home care benefit is about. In order to qualify, you need to show that you are homebound, that you can't get out, right? There has to be a doctor's plan of care, which is going to be your doctor, although typically these plans, the way that you initiate them in kind of as a reality is that you call the VNA. You have somebody from a VNA come in and evaluate your loved one, or you, right? And decide that a care of plan is necessary, right? And that it will, once again, not that it has to make you better. Under Jimbo, it has to keep you the same or keep you from getting worse at such a rapid rate, right? If they do that and the doctor signs this plan of care, then Medicare will pay for these 60-day plans of service. And those 60-day plans of service can be renewed indefinitely. This benefit can last forever, right? People can do these until they die. And now you're on Medicare, right? So to the extent that these services are showing up, but you need other care, like home care or whatever, right? You can supplement that yourself by just paying for those services. Medicare won't pay for them, right? But you don't have to go through the exercise of doing all of the asset transfers and stuff to qualify for Medicaid. And you don't get disqualified by virtue of the fact that you have some money. So you can be in the position where you're using Medicare to cut down the cost of staying at home when you're homebound. Finally, there's the hospice benefit. Briefly, the hospice benefit is about living, not about dying. We all die. We all die. The question is, can we live as well as we can until we die? And the answer is, so don't wait until you're almost dead to think about the hospice benefit, right? The only requirements of the hospice benefit, you need a doctor's certificate that says that you, if things go on the way they are, probably will not live more than 6 months. But these can be extended. The doctor can extend that forever, forever. I've had people, I think the figure that I got from one hospice agency was that 28% of their patients graduate from the hospice benefit, not graduate in that they ascend, they're dead, right? But graduate in that they get better, right? One of the reasons is because of number two. If you're on hospice, right, then you are agreeing that what you want is regarding the thing which is for which you may die in the 6 months. That you want palliative care, that you want care that's going to make your life better, reduce your pain, as opposed to curative care that's going to try to get you better, okay? Now, if you're on the hospice benefit for cancer and it turns out you get pneumonia, right? You still get all of your Medicare benefits to cure the pneumonia and get you better at home. You just are not getting the chemo for the cancer. So it's a really important benefit, and it's a Medicare A benefit. What does Medicare B cover? Covers everything else. Covers everything else that you could think of, right? Other than a very few things. It covers doctors and a bunch of stuff, but one of the things many of you have learned in recent years is that as a result, one of the hard financial impacts of Obamacare was that everybody used to have the same Medicare copay. It was one number for everybody. Now it actually varies by income. So the typical one in 2018 is $134. But as you can see from the chart, and this is also in your handouts, as your income, that's true if your income is less than $85,000 as an individual or less than $170,000 as a couple. Now, it has been my experience dealing with my clients. That pretty much covers a lot of people, right? Covers the vast majority of my clients. But you should just be aware of the fact that if your income is higher than that monthly copay may be higher. The way the system works is that when you get something that is covered by Medicare B, what Medicare will do is they'll send you those bills that no one can read, the incredibly complicated bills. One of the reasons for that is that Medicare, the way Medicare pays, is they take not the amount that the doctor would charge, right? But they take the reasonable charge for whatever was done for you, which is the lowest of the actual, the customary, or the prevailing charge. I won't go over what that is, customary, prevailing. Suffice it to say that that's not what the doctor would like to charge usually, right? So the bill you get basically tells you what Medicare has decided that that number is, the reasonable charge. And then Medicare will tell you in that statement that they send you that they're paying 80% of that, right? Your Medigap, that's another place where your Medigap insurance would apply. If you have Medigap, then Medigap will pay that remaining difference. And the providers are prohibited from charging you more than that. For any of the things that Medicare pays, the provider can't charge you more than the reasonable charge. What does it cover? It covers everything you can think of that isn't the hospital or isn't the other Medicare benefits. It covers physicians and physician supplies, splints, durable medical equipment, medical nutrition therapy. Christine's going to talk a lot about these Medicare C plans, but this is also something that she's doing, so I wanted her to talk about medical nutrition therapy.
Medical nutrition therapy is something that we've started at BayPath in about the last 6 months, and it means we can bill Medicare. We have never billed Medicare before. So this is something very new for us.
It's a big day for them.
It's a big day trying to figure out how to bill Medicare because it's not easy. We have a registered dietitian on staff. Her name is Tracy Robidoux. Tracy, as a registered dietitian, is able to do medical nutrition therapy, which is usually indicated in people who have chronic and severe diseases such as diabetes or kidney disease. In medical nutrition therapy, Tracy would sit with you, go over the diagnoses, go over the diet, and help you make choices that will help you live better with your disease. It has to be prescribed by a doctor. We get the referral from the physician, and we come out and we see you in your house. So if any time along the way you find that you've really got a very difficult disease you're trying to deal with, and you think it may be beneficial to get someone in nutrition to give you some advice, please feel free to call upon us.
Thank you. Here are a few things that they don't cover, right? And you probably know about these. They don't cover most immunizations except the flu. They don't cover eyeglasses. They don't cover dental. They don't cover custodial care. They don't cover care that can be provided by a non-physical therapist, nurse, occupational therapist, unless it's in conjunction with a plan that those folks are doing, typically those 60-day plans. And so they don't cover those things. Medigap policies, very briefly, and many of you folks probably already have one. Medigap policies were designed to fill the gaps that I just described, to fill those deductibles and some of the co-pays and stuff. There are actually 10 officially authorized Medigap policies. I'm not going to go through those. Suffice it to say that all of them at least cover the A and B deductibles and the co-pays, and they typically will also cover a longer stay at the hospital. So if you want to get past that, what I talked about, the 90 days per stay plus the 60 reserve days, if you want more coverage than that, most Medigap policies will give you more coverage than that. Medicare C. Medicare C, the concept behind Medicare C was to encourage health maintenance organizations, to encourage large organizations to basically give you a plan of care that would be instead of all of the individual services you're getting under A and B. And as a result of that, as the incentive for folks or for insurance companies or for providers to do these kinds of plans, they basically said, okay, if a Medicare person hires you, one of those Medicare providers, to provide that plan, and you agree that you're going to provide all of the things that Medicare A and B would have provided, and by the way, also to provide them with the same kinds of appeals processes and stuff in the event that the client doesn't think they're getting the right services. And then we're going to allow you to say that to explain to us the other things that you're going to do that are going to benefit these people, the other programs that you're going to provide. And in return for all of that, we're going to write you a check every month for one big amount, which is basically equal to what we think we would ultimately end up having to pay for this person's care for their lifetime. So Medicare C really was a chance for the market to get involved in this, for individual players to get involved in this, and to provide you with additional services. They have to provide you with the basic Medicare A and B services, all of them, but they can provide you additional services. One of the reasons why, as I mentioned at the beginning, one of the reasons why we're doing this program is because recently Medicare C has indicated that they are revising their regulations so as to specify the kinds of new things that can be allowed under these Medicare C programs. And I think they're really, really important. So I wanted Christine to be talking about those. Well, this is my tech course. That's forward, that's back.
Okay.
That's all I got. That's all I can do,
Okay.
all right?
Thank you. So there's going to be some changes to the Medicare Advantage plans, and these will be starting on January 1st. As Arthur said, Medicare Advantage plans are offered by companies, and they must provide Medicare A and B. So if you're in a Medicare Advantage plan, you still have Medicare. Most Medicare Advantage plans include prescription drug coverage. So if you have Medicare, you probably are on a Medicare Advantage plan, or you have original Medicare with a Medigap. If you have a Medigap policy, you can't be on a Medicare Advantage plan. So it's one or the other. Medigap is considered supplemental to Medicare. So there's 27 different plans from 6 different health insurance providers available in Worcester County. Fallon is probably the closest, Blue Cross Blue Shield, more well-known, Harvard Pilgrim, Tufts. These are all names that all of us know, but there's 27 different plans available at 27 different price points because I looked them up. So currently, some Medicaid Advantage plans offer limited supplemental benefits defined as not covered by original Medicare, that is primarily health-related, and for which a Medicare Advantage plan must incur a direct medical cost. Some Medicare Advantage plans cover things like dental, eyeglasses, which would not be covered under original Medicare, so their benefit can be enhanced a bit, but it is a managed care plan. So this had been, when I say limited, I mean very, very limited supplemental benefits. No one has ever had personal care in their home that's covered under Medicare. That's not going to happen. You'll get a home health aide from the VNA, but you're not going to get a personal care worker on a regular continuing basis for 3, 4, 5 years. That doesn't happen under Medicare. They're not going to pay for these maintenance items as reflected back in the Jimbo case. If it's needed to help maintain you, they're not going to pay it. So CMS, Centers for Medicaid and Medicare Services, has not allowed any item or service to be eligible as a supplemental benefit if the primary purpose includes daily maintenance. All right, somebody coming in to do your medication, somebody to give you personal care. But under the revisions, CMS will allow the supplemental benefits if they are used to diagnose, prevent, or treat an illness or injury, compensate for physical impairments, which is really important, act to ameliorate the functional psychological impact of injuries or health conditions, and the big one is reduce avoidable emergency and healthcare utilization. We know the big thing in the medical community now is about saving money. They're trying to keep you healthier. They don't want you in the hospital. They want you healthier because under the capitated payment system that they're on, they're saving money if you're not in the hospital. Therefore, they want you to be healthier. So non-skilled in-home supports will be included as a supplemental benefit starting in 2019. That is really a significant change in Medicare. And we only heard about this a couple of months ago. And now everyone's scrambling to really try and understand, what does this mean? So what does it mean in terms of what you might be able to get? And I say might because I don't want folks to start thinking that, oh, they're going to do this and this and this and this. It all depends on your diagnoses, what's happening in your home, and they'll be very discerning about what you might need. But if you are a diabetic and have a foot amputation, it may be in your best interest to get a ramp to your house instead of walking up the stairs. It may be helpful for you to get to your medical appointments, so they'll give you medical transportation from home to the medical appointment if you don't have that. If you are missing appointments, which then means you're hospitalized more. So think of someone living with chronic obstructive pulmonary disease or asthma. In the hot, humid weather that we have over this past summer, some days it was just unbelievable outside. And I have asthma, and it was tough. But thankfully, I have air conditioning in my home. If I didn't have an air conditioner, I don't know what I'd do. And that type of weather tends to exacerbate admissions back to the hospital for people with COPD. So it's going to be a lot cheaper for the physician to get you an air conditioner rather than spend $6,000 to $8,000 for you to be in the hospital a couple days so you can recover from not being able to breathe with the hot, humid weather, which then if we have another hot, humid spell, could just happen again. So it's in your best interest and his best interest to get you an air conditioner. They may not pay for getting it in the window. They may not pay for the delivery, but they may buy you an air conditioner. So for those of us at BayPath, one of the most interesting things is personal care for your activities of daily living. And personal care means someone, an aide, to come in and give you assistance with bathing, not directly bathing you, but giving you some assistance, perhaps helping you in and out of the tub. That is not paid for under Medicare. It's paid for by the state home care program in Massachusetts, but it is not paid for by Medicare. Might be paid through long-term insurance, but still not paid through Medicare. And oftentimes, this is one of the items that folks need to remain independent in their home. If someone is incontinent, it's very, very critical that they receive personal care, and good personal care at that, to prevent skin breakdown. Again, this helps you maintain a quality of life, helps you to stay healthier, and in the long run, benefits the physician because you're not in and out of the hospital and you are not declining. So the other examples might be the Adult Day Health Program. Most folks who attend Adult Day Health nowadays are on Medicaid. And things like healthier groceries. For some folks, you may not be able to afford things that are really, really healthy for you, but if it's going to help you heal, if it's going to help you stay at home, that might be something a physician is going to pay for. So the possibilities are really endless. Whoop. So will it be covered? That's the big question. So whether or not a service or product is covered is dependent upon its medical appropriateness. While a prescription or physician's order is not required, a licensed healthcare provider, that translates to an RN, needs to recommend the service for it to be covered. So if you have visiting nurses coming into your home, you could say to them, you know, with my chronic obstructive pulmonary disease, I think I really need an air conditioner. She can get in touch with the doctor's office, she or he can get in touch with the doctor's office and make that recommendation to them. So work with your medical provider to determine what is appropriate for you. All of these items fall under the non-medical field, which is what Medicare has never covered before. They fall under the realm of what we call social determinants of health. Social determinants of health are your housing, it's your nutrition, it's your ability to go and socialize. All of these help you stay healthy and active. And that's what physicians are now really looking at. What are the social determinants of your health that will keep you going? If you're isolated in your home and become depressed, that's an issue. So if you're active and engaged, you're more likely to be healthy. So finally, it's beginning on January 1st, just a couple of months away. I think there's only 14 Fridays until Christmas. And expect confusion. This is a huge change for these folks, and usually it takes a while for things to trickle down. But be persistent. This is a change in the law. It has been in the news. You can Google CMS Supplemental Benefits and find out more about it. So we can help. We already have contracts with people who provide personal care. We have folks who install air conditioners. We have all those kind of things. And if we don't know somebody off the top of our head or have a contract for it, we have information and referral. And they are able to track down a lot of the resources that I might not have on the top of my head. So we can provide you information along the way to make sure that you have a really good quality of life.
That's right, I don't need this. I forgot. Right. So as I mentioned at the beginning, this is a big deal. This is a big deal. For so many of the folks that I deal with who, among other things, are over 70 and can no longer get long-term care insurance, right? And so now they're really stuck if they are worried about this notion of needing a lot of care, needing care at home. This may be able to take care of it. This in terms of being able to deal with adult day health, with a bunch of things. So what Christy and I were just talking about before we started today is we think that what we'll do for the next presentation here is we'll actually invite, we'll see if they come, we will invite two of that handful of companies who are providing these plans so they can actually talk about it, right? And we're not trying to do this as an ad. We want to get folks a sense of what these programs might be able to provide. So that's what we're going to attempt. And we'll see if somebody will show up. But I think expect confusion. This is a major change. It's a major change that's totally regulatory. Most people aren't even aware of it. So expect it. But this could really help change your lives in terms of giving you a great benefit that you really need. Thank you very much. Any questions regarding any of this? I know we covered a lot of stuff. If not, could I ask a quick round of applause for my friend Christy and Alessandro for the great work she does. And thank you very much for coming. I hope lunch was okay, right? And we'll see you in a couple of months. Thank you.